GLP-1 is all the rage right now in terms of what is leading the headlines across media. The reality is that it's important for us to unpack exactly what is GLP-1 and is that the only thing that we need to pay attention to. So the reason why you're seeing these headlines is because of the fact that glucagon-like peptide 1 are new medications that have been developed. These are agonists, meaning that they act on the receptors, but they are not the exact molecule, that have been utilized now for many years for weight loss as well as diabetes control. Glucagon-like peptide 1 is only one of the peptides that we're currently talking about. Another one that is commonly utilized, or we're seeing more and more in the news, is its partner GIP, which is a glucose-dependent insulin-releasing polypeptide. These two peptides actually belong to a class of hormones called incretins. Now, you may have heard of secretins, which were basically things that were being released by the pancreas. Incretins were identified afterwards, and these are intestinal hormones released in response to nutrient ingestion, which then are going to potentially help with this glucose-induced insulin response. So when you're talking about what is its role in regards to diabetes or weight loss, a lot of people are saying this is going to be the wave of the future, and this is what we're going to see continue taking the world by storm. In fact, we've even seen Oprah coming out and saying, like, this is the holy grail. The reality is we now are seeing this move beyond just talking about weight loss and diabetes as well, because of the fact that what's interesting when we're learning about the actual utilization of these molecules and where the receptors of these molecules are. Yes, they're present in the GI system. However, they have widespread distribution, not only throughout the brain, but also on things like the heart and the kidney. Why is this relevant? Because even though we're utilizing these things for weight loss and diabetes, their main mechanism of action at this point, when you're talking specifically about weight loss, actually isn't working directly on the GI system. It's working more so on the brain and having that signaling then be able to impact that peripheral system. So this is counterintuitive to what one would expect. It would expect that because of the fact that this hormone not only circulates in the central nervous system, but also in the periphery, that the mechanism of action of utilizing an agonist would be working on the stomach, it's working on the intestines. But in fact, that actually is likely the minority of its effects, because we recognize when physiologically the body is actually producing this and trying to work at normal function, the main amount of that work is actually coming from the central nervous system. And it actually is relatively unclear of the contributions of the peripheral GLP-1s. So GLP-1s, they are definitely not a one-trick pony. They've already demonstrated they can do at least two things, weight loss and diabetes control. And when we look at that, some would say, is that all representative of the same thing? I'm causing weight loss, and so therefore I'm increasing my insulin sensitivity, and maybe that's why my type 2 diabetes is getting better. However, we recognize, no, GLP-1 has more than one function, just even in that. It actually is improving your insulin sensitivity, and it is also producing weight loss. So doing two different things. We're now seeing the same type of criticisms coming back in regards to, hey, we're using these now in sleep disorders. Is this in fact just another weight loss ploy to get another indication? The reality is I do think that this is part of the story, but not the complete story. We recognize that when looking at the physiologic effects of GLP-1, in addition to the metabolic effects that are appreciated through weight loss and diabetes management, some of that effect is likely also mediated through orexinergic effects. There also has been some data looking at GLP-1 specifically at upper airway tone and seeing whether or not that may potentially modify. Now, when we're seeing GLP-1s, it is really important to say, can this actually make a difference? If I were to objectively utilize this and be able to say, I have someone who has sleep apnea, I have someone who has insomnia, I have someone who has another sleep disorder, do we see any meaningful change? Well, what I can say to you is that we can take translational data and we can tell a really convincing story that GLP-1 actually is definitely more than a one-trick pony. When you look at animal model data and look at does it have any influence of the administration and timing of GLP-1 agonisms, do we see any change in total sleep time or how cycling occurs? In fact, we do. We see that it increases total sleep time, and depending on the timing of day that it's administered, can actually augment the amount of slow wave sleep that these animal models are cycling through. This now is really quite interesting because it introduces other opportunities to say, well, if I can change the ultradian cycling and the quantity of sleep, are there other roles that this may potentially have? Now, again, remember, I have already mentioned that GLP-1 has this direct and indirect interaction with orexin. Orexin is definitely another molecule that is all the rage right now because we're seeing the development of orexin agonists and how that may be potentially meaningful in the treatment of narcolepsy. However, we also know that orexin has significant roles, again, in the quality of sleep and even potentially sleep disorder breathing and your ability to maintain upper airway tone. So we now fast forward and we look at the data that is starting to become available. We have now data that is coming out of the use of a GLP-1 GIP agonist and its influence on obstructive sleep apnea. Large scale phase 3 study looking at individuals who have both obstructive sleep apnea with CPAP use and without CPAP use. Now, when thinking about this, many times we'll just say, well, one of the strategies that if I have someone who has obstructive sleep apnea is weight loss. We recognize that if you look at some of the data, with every 1% change in weight, we expect to see a 2.6% reduction in AHI or apnea-hypopnea index. So that is setting the standard already as to what are the expectations. Now, of course, you can look at a broad range of different studies that give variability in regards to what this weight reduction and what this AHI change is. And likely what that is a reflection of is the fact that there's different endotypes of obstructive sleep apnea. And depending on what your weight and fat distribution is, you may see different benefits or potential risks. And again, making sure we also recognize one size fits all is not what we're talking about here, because obesity is not the only driver for obstructive sleep apnea. Now, with this study that was done, this was a very intentionally designed study that recognized that obstructive sleep apnea more commonly is being diagnosed in men. Unfortunately, likely a biased reflection. When we look at the epidemiologic data, we recognize that between 0 and 18 years of age, it's probably about 1-to-1 of boys and girls being affected equally, 18 to 50. We see this scale of maybe it's anywhere between 2 to 7 times more likely being diagnosed in men versus women, probably a selection bias, but then you get to the age of 50 and it's about 1-to-1. And that really is because menopause is being introduced and we're seeing some significant changes that increase the likelihood for obstructive sleep apnea to be present, but also to finally be diagnosed in women. So why do I give all that statistic and epidemiology is because this study was designed to ensure that it didn't over enroll for men and not have the purposeful inclusion of women to be well represented. And so they did cap at 70% enrollment, men being enrolled. However, all individuals who were enrolled in a study did have to have an elevated BMI greater than 30 and had to have moderate to severe obstructive sleep apnea. What did they find? What they found was that there was substantial body weight loss. And so we were seeing up to about 20% body weight loss. However, what we were also seeing is that the performance of the reduction in AHI exceeded those numbers of seeing that 1 to 2.6% reduction in AHI. So some of the things that I think are really important from this study is that number one, we saw this in individuals who had no CPAP. Why is that important? Because these are untreated individuals. We weren't treating them to begin with, and now I'm modifying a very significant risk for all-cause mortality. And I'm helping them to achieve other ways of actually improving overall risk by potentially modifying their glucose control as well as their weight. So that's a win all around. There's no way that anyone can argue against that. Now, what about individuals who were on CPAP? Did we see any benefit there? Well, let me tell you something. One of the things that is hotly debated, even when you're talking about CPAP use, and this is a little bit different even from the pediatric lens, is that when we modify OSA, do we cause weight loss or weight gain? We recognize in pediatrics, sometimes the failure to thrive phenotype is what we see, where there's an increased metabolic demand because of the obstructive sleep apnea, so we see weight gain. We also can see the opposite of the child who might be overweight And then we get the tonsils and adenoids removed and we see some weight loss. And so it can go in either direction. In the adult world, we see very similar phenomena of that. We introduce a CPAP as treatment, we optimize the AHI, and there's some people, because they have increased energy, they're able to do better. Their leptin and ghrelin might be more stable, so they're having better food-seeking behavior and more nutritious food choices. We see that it gets better. However, equally, we see individuals who have weight gain. Now, with this stated, this enrolled individuals who have obstructive sleep apnea and a BMI greater than 30, and they're on CPAP. So we're already dealing with a population who they need weight loss. That's only going to add to the benefit. And so what we're doing here is we're seeing whether or not do they achieve as much benefit as those who are getting no treatment at all. Well, what did we find? It actually was even better. We saw not only was there weight loss, but we saw even further reduction of the AHI. And so with that stated, what we're finding is that this is making a difference beyond just the weight loss. We're seeing that it's not negatively impacting the CPAP adherence, although that was a part of the protocol. They could not become less adherent. However, it also is raising this thought of, are there other mechanisms that are contributing to the benefit? My personal theory is that there likely is some orexinergic effect. In addition to that, just as we saw in animal models, increased total sleep time and improvement in slow wave sleep, I'm putting you in a stage of sleep that is going to be protective to provide more stable breathing. So overall, I think that this is a win-win-win. Do I think this puts CPAPs out of business? Absolutely not. Do I think it broadens the segment of population who actually will finally be diagnosed and looking for treatment? Absolutely. Does it give me more tools in my tool belt to actually treat every individual with an individualized plan? Yes. And it's just a reminder that we're seeing a broadening of different treatments becoming available for all sleep disorders. And so recognizing this is an epidemic in the United States, we need to be mindful of identifying, optimally treating, and remembering sleep is a tool for you to get your best health, wellness, and performance. Live your best life.